pediatric dermatologist working at Riley. So today, both of them going to give a talk on the imaging findings when the clinician or the dermatologist seeing something on the patient's skin and what do they need to know from us on the neuroimaging. So welcome Drew for lectures and welcome Jenna.
Thank you for having us, Tanya. Yes, we're
you.
delighted to speak this morning.
Yes. Yeah, it's all yours now.
Okay, let me get my screen
and unfortunately,
shared.
we cannot see your face, but we're
I
gonna
know, I'm sorry. Yeah, we don't have a camera working on the station this morning, so I apologize. I'm not able to see you all. Well, I can see you, but you can't see me.
No, but that's okay. We're gonna put your photo.
An interest in imaging and what tests that they need to order and how we can optimize that imaging and what they're looking for, what they need to know to help take care of the patient. So we're going to determine who to image, what protocol we need to select, and then cover a variety of conditions today, including neural tube dysraphisms, a couple of phecomatoses, congenital melanocytic nevi, a connective tissue disorder, and then we're going to cover vascular anomalies as well. And then after we review some of the clinical info, then we'll review illustrative imaging examples of those as well. So here's our outline for today. So let's jump right in with neural tube dysraphisms. So our first condition we're going to discuss is aplasia cutis.
All right, so when we see, this is an example of one of my patients who came into clinic. Parents often report that they saw this soon after birth, right when baby came out, they see this area where there's missing skin. Sometimes this can be covered in like a blister formation. Sometimes it's just kind of this pink look to it. So aplasia cutis is localized absence of skin. It can be isolated, and most frequently we see it being isolated, but it can also be associated with underlying cranial or cerebrovascular defects, and that's the reason why we're thinking about imaging these. So the patients that I worry about the most having that underlying defect are those that have a hair color sign. And this has an example of a hair color where you can kind of see this little bit of thicker hair. It's like a little bit more luxurious, and it often kind of swings around the missing area of hair. Sometimes it can even be like jet black or a lot darker than the other hair. And then the other ones that we worry about are when they're midline. So the midline location, especially if it's posterior to the vertex of the occiput or within 3 centimeters of the midline. And then if there's aplasia cutis, so missing skin plus a vascular stain, or I feel a nodule nearby, that raises my suspicion even more. And so typically we think about getting an ultrasound when they're young, and then after around by 6 months or so, then we think about whether we need to do an MRI to further evaluate.
Are you guys able to see the mouse when I'm pointing to structures, or not so much?
Where is your mouse? Can you move it again?
I'm moving it right now. Are you able to see it?
Not that much.
No. Okay. All right. Well, we'll do the best we can. All right, so here's an example from the literature that we can see in the right occipital bone. This is a CT 3D reconstruction of the skull, and we can see that there's this large area of deficient bone in the right occipital bone, kind of abutting the lambdoid suture. So this was an example that had an area of aplasia cutis right in that region, and subjacent to it, there'd be this large bony defect. So that's what we're looking for. Here's another patient with an axial T2 weighted image on the right of the screen, and we can see that there's an arrow pointing to an area of focal thinning and probably absence of the left occipital calvarium. So that little thin black line that we're visualizing is actually probably dura. And we see the thicker T2 hypointensity next to those regions is the normal calvarium. So that's what we're looking for on our MR imaging. This was a patient that was, I don't remember how old they were. I think they're about 5 or 6. So we can see this very large area of deficient bone at the posterior vertex. So, if this is a young patient, you'd be like, wow, is this just a really large posterior fontanelle? But this patient was like 5 or 6 years old. So this was actually just a very large calvarial defect adjacent to an area of aplasia cutis. And then here was another image. So let's see, is Paul on?
Yeah, I'm here. Can you hear me?
Oh, yeah. Can you just describe what you're seeing on these two images?
Looks like we have. Let me zoom in here on my phone. Looks like we have some MR images. Looks like we have T1 weighted, T2 weighted as well. Sagittal views through kind of the midline, maybe a little lateral to midline. You know, I am kind of drawn to this area of kind of in the parietal occipital lobe. I'm wondering if there's too many gyral folds there. Kind of tough to tell.
I'm going to pass the brain for you because
okay.
we're just volume averaging through a region. So yeah, it does look a little funny in that parietal occipital region. I agree. So let's focus on the more superficial structures in this case.
So, you know, kind of going off what we were talking about, looks like maybe there's I'm wondering if there's a little skin defect there, kind of in the same region, high parietal area, that looks to be thin. There's probably a little piece of calvarium missing. You know, could that be the posterior fontanelle? Possibly, but it looks kind of more posterior than I'd think.
Right.
So
exactly. Yeah. So you know, when we see this on our T1 weighted sequence, we can see the scalp fat as being nice and T1 bright, right? And then we see that kind of a focal interruption there at the posterior vertex. And you're exactly right. We're a little off midline here because we can see globe here anteriorly. But you see that focal kind of deficiency of the scalp fat at the posterior vertex. And it's subtle, but if you look deep to that region, then you see the T1 hypointense line of the outer table of the cortex. So the bone actually is intact here. So the bone, you know, can always be a little bit tricky to visualize on MR, but you always want to remember, so your inner and outer tables of the cortex are going to be nice and dark on both your T1 and T2 sequence. And then, you know, you want to see that T1 and T2 hyperintense fatty marrow. So we can see that there's that T1 hypointensity of the bone that looks intact. Similarly, this is a sagittal T2 space sequence. This is a 3D, heavily T2 weighted sequence. And we have a very nice look at that deficient scalp fat where the area of the skin is absent. But we do see that T2 hypointensity of the outer table that looks intact. So when protocoling an exam, a sagittal T2 space or even a cyst is often a nice sequence to add on to these patients in addition to our routine brain images, just because of that anatomic detail that you get. So that always is helpful to add on. You know, in regards to contrast, you could kind of go both ways. Sometimes, you know, if they're right in the midline and we want to see like what's going on with the superior sagittal sinus, contrast can be helpful. I will say kind of anecdotally, I see just as many of these without contrast. So I feel like you'll see both. So it's kind of plus minus. There's not any set standard of care with that in regards to contrast imaging. So good job, Paul. Okay, so those are kind of the findings that we see with aplasia cutis. All right, so we're going to move on to our next entity, dermoid cysts.
So dermoid cysts, we see these a lot in our clinic. So babies, infants come in, they usually are complaining about a bump, sometimes on their nose, sometimes forehead, around the eyes. These arise from entrapment of skin along the embryonal fusion lines, and they're lined by skin, but it can also be associated with adnexal structures. And the problem with these is that over time, as they grow, they can kind of push on the bone, and sometimes they can cause intracranial extension. And so the most common, I'll kind of show you on the next slide, but the ones that we worry about are the ones that are located along the midline. And I have a good image here to show you. So we call these cutaneous hot spots, where you can see these red circles, and those areas kind of represent where the fusion of the neural tube segment occurs. And so when I see a lump or nodule kind of anywhere in these locations, it raises my suspicion or concern for a potential extension. And this, I wanted to include this picture of one of my patients because this is the most common location where we see dermoid cysts. They usually occur over the orbital ridge. And I teach our dermatology residents and pediatric dermatology fellows that we don't actually have to be concerned. Usually when they are located over on the orbital ridge, they do push on the cranium, on the bone, but they don't usually have any issues with extension. So we actually don't image these. I frequently just reassure families, but we do refer these and have them removed because over time they can push on the bone and cause issues and they won't go away. So we usually do have them removed, but I don't send them for imaging. However, if the same thing, again, in that first picture, when that was located in that midline on the nose, that baby I would send for imaging.
Okay, so let's jump into some images here. Alex, are you on?
Yeah, can I take the next one? Sorry.
Yeah, of course. Kenneth, are you on?
Yeah, can you hear me?
Okay, yeah, I can hear you just fine. Can you take this case?
Sure. So we have axial T1 non-contrast, and then we have a axial T2, and then we have ADC.
Yes.
And so on the T1, there's a well-defined kind of intermediate intensity lesion in the right, like periorbital region, next to the anterior part of the zygoma, and lateral wall of the right orbit. And then on T2, it's also kind of intermediate intensity. And then it looks like it's more dark on the ADC, so I would think that it has some restricted diffusion.
Right. Exactly. Yeah, exactly. So great job. Yeah, that's the lesion on this one. It's on the right. So as Jenna said, this is a very common location that we'll see dermoid cysts. And, you know, of note, we don't really typically see those dermal sinus tracts of the ones associated with these. So she doesn't order imaging at least up front. I will say, you know, just with clinical experience, a lot of times the plastic surgeon may or may not order imaging for these just for surgical planning. So we will see these. But as far as, you know, management of, like, if there's a tract that needs to be resected from neurosurgery perspective, things of that sort, low risk in this location. So yeah, signal characteristics, they're kind of varying T1 signal because of the varying degree of internal fat. So if it has a lot of fat content, it'll be nice and bright. If not, it may be more intermediate or even lower signal. They're often T2 bright, but fairly heterogeneous. May or may not show restricted diffusion. In regards to the post-contrast appearance, you know, you may have some peripheral enhancement. You should not see solid enhancement. You know, if there is super infection, of course, you can have very thick peripheral enhancement and adjacent inflammatory change. And that's really one of the main reasons that these all get resected, is because of the, you know, risk of secondary infection and with those dermal sinus tracts as well. So great job, Kenneth. So here's a couple other examples that we'll just kind of go through. So here's one more in the midline. So this is one that if Jenna saw in her clinic, she definitely would order imaging on. Right in the midline, located just above the nasal bridge, inferior frontal region, we see this low density rounded focus. It's quite small. You can see there's a little bit of scalloping of that subjacent bone. But we don't see any evidence of any extension into the bone, although I'm not showing that optimally without the bone algorithm images. But this was one that would definitely get imaged given that midline location. So here's some graphics from StatDX, borrowing just because I feel like they show these findings so nicely. So on the left image is our nice illustration showing that rounded dermoid cyst along the nasal dorsum, and then shows that associated dermal sinus tract that goes up through the nasal cavity, and the potential for these to go intracranially. So they go up through the anterior skull base through foramen cecum, and then you can have varying components of intracranial dermoid involvement as well. So the middle image is a sagittal T2, probably a cyst sequence, so heavily T2 weighted, volumetric, nice and thin section sequence. And you can see that rounded T2 hyperintense lesion along the nasal dorsum with that T2 hyperintense tract extending through the nasal cavity up through foramen cecum. It doesn't really extend into the intracranial compartment, kind of stops at foramen cecum and widens it. But this is one that would get resected. The far right image, another sagittal T2 weighted sequence showing that dermal sinus tract, and this one does kind of pooch into the intracranial compartment with the component going superiorly there. Here's another one that we've had at Riley. So we can see that T2 hyperintense lesion along the nasal dorsum. You can see that contour change. So you can see how clinically that would certainly be quite apparent. And then that linear T2 hyperintense structure going through the nasal cavity up towards foramen cecum. So differential wise, there's certainly differential for this location. One of the big ones that we want to think about is, could this be a frontoethmoidal cephalocele? So is this actually brain parenchyma coming down through foramen cecum into the nasal cavity? So just a nice graphic from StatDX showing that phenomenon, and a sagittal T2 weighted sequence showing that herniated parenchyma through foramen cecum with a very large frontoethmoidal cephalocele into the nasal cavity. So we want to keep that in the back of our mind as a differential. Another one would be nasal glial heterotopia. So you'll see these, referred to as nasal glioma, which is obviously a misnomer, but it's just heterotopic glial tissue. So these also occur in the nasal cavity along the nasal dorsum. They can look quite similar to a dermoid. So you can see why this is definitely going to be your differential in these cases. But T2 bright can be intermediate T1. Again, it won't show any enhancement. So this is a typical location for nasal glial heterotopia as well. Here was a case of a nasal glial heterotopia we had at Riley in the last year or so. Heterogeneous T2 bright lesion in the nasal cavity. We see it looks kind of intermediate to low signal on T1. Just a little bit of peripheral enhancement here on the axial post-contrast images. So that one's path proven. Okay, so that kind of rounds out our dermoid cyst and our discussion of those midline neural tube dysraphisms kind of in the face region, face and head region. So now we're going to move to the neural tube dysraphisms involving the spine.
All right, so I use this table really frequently. This comes from one of our pediatric dermatology journals from 2015. And it's really helpful for us to kind of think about which individuals we do need to image or have higher concern for. So very frequently babies come in and we're doing our exam and we kind of see a couple of these things. I'm actually going to start on the low, so at the bottom, and work the way up because, these are the ones I most commonly see. So if we have a simple dimple, and so when I'm doing my exam and I'm splitting the butt cheek area and kind of looking to make sure that there's no pits or dimples, I very frequently can see these simple dimples, and those are small. They're less than 5 millimeters. They're not far from the anal verge. So we think about that number of 2.5 centimeters. So they're close to that anal verge, and I can see the base of the dimple. And so for those kids, I don't need to do any imaging. Same thing if you have some hyperpigmentation, so a brown lesion or blue. We think about dermal melanocytosis, which is very frequent in patients in skin of color. You have this bluish pigmentation. Those individuals don't need imaged. And then moles, that's the fancy term for that is melanocytic nevi, which we're going to talk a lot more about later in the talk. But if we have a melanocytic nevi in that location, we can start thinking about whether we need to image. There's some complexity to that, and I will talk about that a little bit more when we get there. Usually port wine stains in this location rarely have issues. And again, there's a little complexity. Sometimes we would do an ultrasound if they're young, but often don't have to do any imaging. But moving up to those that have a little bit higher concern. So if I'm seeing hypertrichosis, now some patients have very commonly with certain ethnic backgrounds, you can have some hair. That's what hypertrichosis means, like excess hair. So a little bit of hair, seeing some dark brown hair is frequent and common, and I don't worry about that. But when I'm thinking about true hypertrichosis, what that means, like a silky down, is where it's like thick, luxurious, dark black hair, really long. That's when I'm more worried. That in infantile hemangioma, smaller infantile hemangiomas, less concern, but they do have a little bit of an intermediate risk. And so I'm starting to raise my suspicion about whether I need to image those. And we're going to talk about those a lot more later in the talk too. And then what we call an atypical dimple. So those are ones that are larger, so over 5 millimeters or farther away from that anal verge. In younger kids, I'd like to see these kids early because then it's a lot easier. We often are thinking about doing ultrasounds as kind of the first thing to screen. And then if there's concerns, then we move to the MRI. But older kids, we usually do have to order an MRI. And then our higher risk category, these are large infantile hemangiomas, so over 2.5 centimeters or more. If I'm seeing a lump or a nodule, we talked about that picture with those hot spots. Remember those red circles? We were earlier focusing on the face and scalp and neck, but down low in the lumbosacral spine, if I'm seeing a nodule there, that raises my concern. And acrocordon is a term we use for skin tag. So that's a fancy term for skin tag. So if I'm seeing a skin tag or a hard, at times we can see these hard, firm, filiform-like nodules that come out kind of like a finger-like look to them. Higher concerns, a fatty growth, or if you have two of these things. So anytime we're seeing two of something, same thing on the back of the scalp, that makes me more concerned and I'm ordering imaging for those.
All right, and then in regards to, if we're going to do an MRI with consideration to contrast, we usually do not need contrast in these cases. So that's just one thing to think about protocol-wise. All right, so let's just kind of form this in our mind of categorizing this very large group of heterogeneous group of spinal dysraphism. So the first thing we want to think about, is it open or closed? So our two open spinal dysraphisms are going to be your myelocele and a myelomeningocele. Your closed spinal dysraphisms, it can be helpful to think about them as, is there an associated subcutaneous mass or not? So if there's a subcutaneous mass or lesion, one of the more common ones that we will see are the lipomyelocele or a lipomyelomeningocele, and we'll go through some examples of that. There are myelocystoceles, and those can be terminal or non-terminal. You can just have just a simple meningocele. There's also an entity called limital dorsal myeloschisis, which is quite rare. We won't cover that today. And then if there's not a subcutaneous mass, some other conditions that we can see are just an intradural or filar lipoma, or just, that fatty infiltration of the phylum that we see quite frequently. Dorsal dermal sinus tracts, neuroenteric cysts, and split cord malformations. So very heterogeneous group of disorders. We're going to cover just a few just for the sake of time. Okay, so our first one we're going to discuss here is a lipomyelocele. So if we remember, this was in our closed spinal dysraphism category that would have an associated subcutaneous lesion, on exam. So this is a nice illustration from StatDX that shows the low-lying spinal cord coming down. We see this large dorsal dysraphic defect. So we have absent posterior elements here of the lumbosacral region. The low-lying cord comes down, and we have this broad interface with fat, right? So when we look at this and we're trying to decide, is it a lipomyelocele or a lipomyelomeningocele, we really want to pay attention to that interface of where that low-lying cord has the interface with fat. So if that's located within the spinal canal, that's a lipomyelocele. So that's what we're seeing here. So here on our sagittal T1 weighted sequence, we see the low-lying cord coming down all the way to probably S1, and we see that interface with the intraspinal fat, and it's within the spinal canal. We see that it's skin covered and lots of subcu fat, so this is a lipomyelocele. So in contradistinction, we have a lipomyelomeningocele. That interface with the low-lying cord and the neural placodes. The neural placode is a term that we use for the distal tip of that low-lying cord, because there's not really a true conus in these cases, right? So when that extends beyond the confines of the spinal canal, that's when we have the lipomyelomeningocele. And then you may see, that actual meningocele component that has CSF pooching out in it as well. So here's our example on a sagittal T1 weighted sequence. Again, we have the low-lying cord coming down. We have pretty extensive intraspinal fat. And you'd say, well, isn't this actually just a lipomyelocele? That interface is all within the canal. But if you keep following the neural placode down, that linear, kind of curvilinear T1 low signal that is continuing on is all actually neural placode, and that goes all the way beyond the confines of that dysraphic defect. So this is a lipomyelomeningocele. Okay, so here would be our example again of a closed dysraphism that does not have an associated subcutaneous mass, so intradural or filar lipoma, right? So it's fat kind of insinuated along the conus. Nice example from StatDX, just a sagittal T1 hyperintense fatty lesion showing intimately associated with that conus. Another one with a little more long segment with that fatty thickening of the phylum going down inferiorly. So these certainly can be associated with cord tethering. Just a side point, cord tethering really is a clinical diagnosis. So we can see some findings that would be associated with it. But, if we just see a fatty phylum in and of itself, we don't know if they're functionally tethered or not. So, they have to do urodynamic studies and assess their gait, all kinds of issues. So I usually typically steer away from saying like there's no cord tethering in my reports or and just be more descriptive. And then, based on the clinical assessment, decide if they're functionally tethered or not. A little nuanced, but that's kind of my approach. So here's an example again, and in that category, this would be a complex dysraphism that's closed. So we have a sagittal graphic here on from StatDX, and we can see that this one has this tuft of hair in the dorsal subcu fat. Shows and illustrates a dermal sinus tract that goes intrathecal with an associated dermoid cyst. So here is a case that we had at Riley that we can see there's a cutaneous marker. So in the middle sagittal T2 weighted sequence, we can see there's a marker placed denoting the site of this kind of defect within the skin. And we can see that there's that linear low signal intensity tract that's going through the fat, through the dorsal elements and into the thecal sac. On the sagittal T1 sequence, we can see that there's very heterogeneous T1 signal showing a lot of fat, and it's associated with the low-lying cord and that neural placode. And that interface, again, is within the spinal canal, so that's a lipomyelocele component. And then at that distal cord, at the neural placode, there's also this kind of intermediate ovoid T1 lesion, and it's T2 hyperintense. So in that far right image, you can see that there's this ovoid T2 hyperintense lesion, and that's an associated dermoid cyst. So this is a complex case that has basically this dorsal dermal sinus tract with an associated lipomyelocele and an intraspinal dermoid cyst. Okay, so we're going to move on now to our congenital melanocytic nevi.
So when I was putting this lecture together, Drew would often emphasize to me that I know it's been a while since a lot of you have been doing skin disease. So a congenital melanocytic nevi is just a fancy word for these moles that we see at birth. So some kids come out with very small moles, some come out with very large ones. So we categorize these. So smaller ones that are less than 1.5 centimeters. Medium is 1.5 centimeters to 20 centimeters. Large are greater than 20 centimeters to 40 centimeters. And then giant are over 40 centimeters. The really important thing to note with these is this is actually size based off of prediction when they are an adult. And so you can imagine when a baby comes out with one that's closer to the smaller end of that, you have to think about what that size will be later. Fortunately, there's really good calculations for this. We actually have a tool that we can use. So what happens is when a baby comes in, I actually measure these. I look at a graph based off of their age and the size, and then I follow that graph and it can predict what size that will be when they are an adult. And that's what I'm going off of. And the reason this is important is there's different risks depending on the size of the skin lesion at birth. There's different risks or concerns. And then the big thing that kind of links with the imaging is what we worry about is something called neurocutaneous melanosis. So that's when you have a mole, and then you also can have some of that involvement of the neural entities. And so that's what we're thinking about imaging for. And neurocutaneous melanosis is a risk factor for melanoma, which you can develop in the CNS. And so that's kind of the thing we worry about the most, because we obviously can't really screen for that as often as we can for looking at the skin for the development of melanoma over time. And so low risk are those that have a solitary, small, medium, and large. And just to flip back, that's pretty large. So large is over 20 centimeters to 40 centimeters. So those really have an overall pretty low risk. high-risk patients for neurocutaneous melanosis are when you have multiple medium. So baby comes into me and they have one on the chest and they have one on the leg, they have one on the back, all measuring in that medium-sized category. Those are ones that I would image. The other term, we used to use this term called satellite lesions a lot because they look a lot smaller. Than often kids would have like one big one and they have a bunch of these small ones. We're kind of getting away from that term a little bit more, but when you have 10 or more of those other lesions, that is worrisome. So it gets away. They don't have to be a complete medium size, but when you have a bunch of those included, and then one larger one, and then giant are always a high risk. And so we usually order an MRI without contrast of the head and the total spine. We try to do this early. So I like these babies to be referred to me as soon as they can, because if I can see them early and get them in, you guys were able to do the feed and swaddle under 2 to 3 months. And then after 9 months, the imaging is pretty limited, which I think Drew will probably mention to you.
Right. So, the key thing, what we're looking for with neurocutaneous melanosis is the T1 hyperintense melanotic deposits, right? So if we're looking for that, particularly for parenchymal disease, we're looking for T1 hyperintensity in the brain. Well, what happens over that first year of life with a infant brain? It myelinates, right? And so as we myelinate, we get increased T1 signal throughout the white matter. So if we wait too long, a lot of the areas that we can see the melanotic deposits as it myelinates could be completely obscured and we have no chance of seeing it. So very important that these get into us as early as possible so that we have that contrast to be able to identify the T1 hypertense foci. So it has certainly come up where Jenna calls me and says, hey, I had this patient, they weren't referred to me in time, they're now a year old. Do I still image? And I usually say yes, because there's certainly times that you can still see it. It's very subtle. But some of the locations like the amygdala, for example, you usually can still pick it up. It's a lot more subtle than it would be if you imaged earlier. And then, of course, if there's any leptomeningeal disease, we would still usually be able to identify that. Okay, so I do think it is still worth imaging, but we have far greater sensitivity to detect these before myelination has occurred. The other thing is from an ordering standpoint is we don't want to be doing like a fast brain protocol or fast spine protocol for these screening exams. We really want to have good high resolution imaging.
And so this is another one of our papers. This was published in the British Journal of Dermatology. And I like this. It helps us kind of thinking about what the results mean. So like, why are we ordering imaging? Like, does it matter for us? And it does show that actually abnormal result on an MRI is actually has a higher statistical predictor of a clinical outcome than actually what I'm seeing on the skin. So don't love that, right? That's better. But it means that the imaging is very important. And so that's helpful for us to know. And so if you have a single congenital nevus, just a small one, we kind of talked about those and we don't need to image. We just make sure, on the left of this graph following this flow chart, just make sure to follow their development. And I just see them in pediatric dermatology clinic and regularly follow them. If they're having any abnormal neurological signs, I'm always asking, are they hitting all their developmental milestones? If there's any concerns, even if it is a single one, then we would go forward and order that MRI. And again, this paper is saying, this ideally within the first 6 months. And then flipping over to the right side of the flowchart, because I know you can't follow my mouse as much here. If there's multiple, and they're less than 2, still thinking about imaging, but over 2 years of age, this paper is kind of saying just follow their development, but if there's any issues with their development, then image. And then if they're doing well neurologically and developing well, we usually just follow them in clinics every 6 months or so. And then I spread those out once they're doing well and following with their pediatrician in school. I don't have to see them as often. But coming down to the part of the graph that flowchart that's showing after imaging, like, why are we imaging? What are we looking for? What does it matter for these patients? Well, it really matters a lot for them and for a parent that's getting this counseling. So if on the imaging, we don't see much there. There's just some other things different from the intraparenchymal melanosis. Usually we just refer them to neurosurgery depending on what that's showing. And I think Drew's going to go into some of these imaging findings, or we refer them to neurology just to kind of follow and do really good neurologic assessments. If there's just the intraparenchymal melanosis only, and this is helpful because I get these not infrequently back from Drew or other pediatric neuroradiologists. Those kiddos, I don't have to do any repeat imaging. We usually just do annual assessments of development with their neurologist. So I just refer them to neurology just to make sure they're developing well. The risk here is thinking about like seizures and things. And then if it's normal, we don't have to repeat any imaging.
Okay. All right, so let's jump into some imaging. I think that was a really helpful review of kind of the importance of our imaging and how these patients are stratified in different risk categories. Abdul, are you available?
Yes, I am.
Okay, great. I'll have you take this case. I know it's a little fuzzy and blurry, but you know what? It's kind of the reality of doing these feed and swaddle 2 to 3 month old babies. So we get used to reading it.
All right, no problem. So we have an axial T1 on the left and right side of the screen, and we can see that the pediatric age group, we can see the gray matter is white and white matter is gray, which is going to be turned to the adult phenomenon by age of 1 on T1 and by age of 2 on T2. And here we can see on the right side of the screen there's a focal lesion in the, I think that is right left cerebral peduncle, showing increased T1 signal intensity, likely, as we spoke about, some melanosis, melanotic lesion there, showing signal hyperintensity.
Right. Yeah, exactly. So this one is, I would localize it probably in the dentate nucleus. So yeah, there's a T1 hyperintense focus in the left dentate nucleus. And then on the image on the left of the screen, we can see that these ones are subtle. And if you don't know where to look, sometimes these can be hard to pick up. But there's areas of T1 hyperintensity in the amygdala bilaterally. So if you look in those medial temporal lobes, we can see that there's T1 hyperintense foci in those regions as well. And the amygdala is probably the most common location that we see parenchymal melanosis. With dentate nuclei is common, cerebellar white matter is fairly common. But these are 2 very common locations that we'll see parenchymal melanosis. So what's important to know, as Jenna said, is when we just see the parenchymal melanosis alone, they don't have a huge risk for melanoma. We don't have to do routine following. They usually do quite well. So it's really kind of the leptomeningeal disease that is higher risk for having seizures and melanoma, things of that sort. I personally have never seen a case of actually having leptomeningeal involvement in my short career so far, but certainly seen numerous cases of parenchymal melanosis. So great job, Abdul. Here's just a couple of images from StatDX that show that, again, kind of that T1 hyperintensity here in the right ventral pons. And this is a nice example to show you, what this looks like on a background of myelinated brain. So you can see the pons and the middle cerebellar peduncles, and some of that cerebellar white matter is myelinated here. It is still T1 bright and a little bit beyond, more intense than that myelinated white matter, but you certainly don't have the conspicuity that you have in areas when the white matter is unmyelinated. So that's kind of a nice example to show that. Another example here from StatDX, it shows the T1 hyperintense foci in the medial temporal lobes, and then this would be a leptomeningeal deposit in the right ambient cistern. So this would be a larger area. This is one that certainly would require a multidisciplinary approach to care for this child, given that there is increased risk of developing melanoma. They're probably going to require more imaging surveillance in a case like this, and have a higher risk of seizures, etc. Another case here from Riley that we've had. So again, we see an unmyelinated brain here on these T1 weighted images, that all the white matter looks nice and dark. We have areas of T1 hyperintensity here in the left frontoparietal region on that top left image. Top right image, we have kind of a triangular focus of T1 hyperintensity center at the right caudothalamic groove. The bottom left image, a small kind of punctate T1 hypertense focus adjacent to the left lateral ventricular body. And then the bottom right image, we've got two foci of T1 hyperintensity and the right amygdala in that medial temporal region. So nice example of multifocal areas of parenchymal melanosis. In regards to what we see in the cord, you can have intramedullary foci of T1 hyperintensity and of course left meningeal involvement as well. So that's what we're looking for on neurocutaneous melanosis screening exams. Okay, so we're going to go into a couple of phacomatoses here, starting with one very common one, being neurofibromatosis type 1.
So I think this is nice for you guys to see what we're seeing in clinic. So I think this talk's super fun. But just to remind you guys, again, it may have been a while, but depending on where you're at in your training. So neurofibromatosis is an autosomal dominant mutation, but I do want to point out, because I think it's not always discussed, but there's a 50% rate of new mutations. And so very frequently, patients do not have a family history of this. And this is when it comes in to clinic for us, and we're seeing these, that it raises our suspicion. So when you see 6 of the CAM, I apologize, probably should have written that out, is a cafe au lait macule. So 6 cafe au lait macules that are at least a half a centimeter before puberty. So in my young infants, when they're coming in 1 year of age, and they're having at least 6 of these. And then in adults, we count them only when they're 1.5 centimeters or larger. Freckling of the axillary and inguinal region. So what that means is you're seeing kind of these, what you think about freckles like on the cheeks, you're seeing a bunch of those in the axillary vault. And then other things that you can see on the skin or other concerns from the eye standpoint, they can have plexiform neurofibromas. They have these Lish nodules. Lish nodules are where you have some pigmentation. It's actually not a concern. It doesn't cause problems for them, but it can help with diagnosis. And they can have optic gliomas. So we always refer out to ophthalmology as well. And then from a neuro standpoint, they can have pilocytic astrocytomas, meningiomas, and developmental delay. And this picture is just showing, these are very typical cafe au lait macules that we see in neurofibromatosis. So lots of patients, especially in skin of color, can have some birthmarks and have more like atypical cafe au laits. I see those every day, all the time. But what I like to teach our residents and really emphasize is the smooth borders of the cafe au laits. So they're not as stellate or pokey. They kind of have a nice circle around them. And those are the ones that are higher risk for NF1. Okay,
so we certainly see NF1 cases all the time on our PEDS neuro service, so you guys will become very familiar with this for the trainees. So we'll go through some of the findings that we see with NF1 patients. So let's start here. Alex, are you available now?
Yeah.
Okay, can you describe what you see on these images?
So I'm thinking these are flare.
Yes, exactly.
Okay, cool. Some axial flare, seeing some like T2 flare hyperintensity kind of in the right globus pallidus there on the leftmost image, maybe a little bit on the left. In the middle image, maybe some T2 flare hyperintensity kind of in the level of the mesial temporal lobes, maybe some hippocampus or maybe the midbrain.
Yes.
And then also on the rightwardmost image and the cerebellum, some signal abnormality kind of in the medial cerebellum, maybe dentate nuclei.
Yeah, exactly. Great job. So what do you think these are?
Not sure.
So we typically will just describe these as NF1 related dysplasias. So microscopically, if the pathologist looks at these under the microscope under their histology evaluation, it's actually like a spongiform dysplasia. So we typically just call these NF1 related dysplasias. So typical locations are the ones I'm kind of demonstrating here. Globus pallidus, very common location. There are sites of the basal ganglia as well. You can have them in dorsal thalami, hippocampi, medial temporal regions, as you said, brainstem, dentate nuclei, and cerebellar white matter. So, usually they're more ill-defined, don't have those circumscribed margins. to help try to differentiate from a low-grade glioma, because as Jenna said, these patients certainly have an increased risk for developing low-grade gliomas as well. So what makes us then question a low-grade glioma? Well, if it's more defined, if it enhances, if it's fairly large, those would certainly raise suspicion, and those patients we would probably follow a little bit closer. So otherwise, these areas of signal abnormality, we typically just call dysplasias. All right. You get a bonus one. I'll have you describe this one too, Alex.
Yeah, so it kind of looks like the optic nerves bilaterally are a little bit sort of larger than normal.
Yes.
Kind of thinking like optic nerve gliomas. And on the right, look, so the left worst image was a T2 fat sat, and on the right we're looking at a post-con, maybe seeing some enhancement kind of along the nerve sheath, but yeah, thinking optic nerve gliomas.
Yes, exactly. So this is a nice example of bilateral optic nerve gliomas involving the intraorbital segments, maybe a little bit of that canalicular segment on the left. There's a little bit of mild enhancement associated with the right optic nerve that we can see. The optic nerve gliomas may or may not demonstrate enhancement. So don't let that dissuade you. If you have an enlarged nerve like this and it doesn't enhance, it's still an optic nerve glioma. So yeah, and these can involve, just the intraorbital nerves. They can involve the canalicular segments, prechiasmatic nerves. They can be extensive and involve the chiasm and even go up into the hypothalamus. So sometimes you'll see these as a large chiasmatic hypothalamic glioma. They can go along the optic tracts and even go very extensively up into kind of the basal ganglia as well. So they can be very infiltrative as well and large. But these ones, this example is just the intraorbital segments here, bilateral optic nerve gliomas. All right, I won't keep torturing you. I'll describe this one. So these are axial T2 weighted images showing that we have kind of right sphenoid wing dysplasia. So when we talk about that as a finding of NF1, that the sphenoid bone, particularly the greater wing, is often going to be small, kind of distorted. That'll result in kind of asymmetric prominence of the middle cranial fossa. So we've got right sphenoid wing dysplasia here, and that's frequently associated with a plexiform neurofibroma. So we can see out here, just lateral to the greater wing of the sphenoid in the soft tissues, we've got this kind of infiltrative appearing T2 hyperintense lesion lateral to the orbit involving the temporalis muscles, so the suprazygomatic masticator space. That is suspicious for a plexiform neurofibroma. And if we look at the middle image, we can see that there's kind of greater than expected T2 signal within the right masticator space. So you're going to be able to see some T2 signal all the time in those pterygoids from the pterygoid venous plexus, but this is greater than expected. So this is extension into the masticator space there. And then on the far right image, again, greater than expected T2 signal in the pterygoid region. So more involvement of that plexiform neurofibroma. Here's another example of a plexiform neurofibroma. So on an axial T2, you often will have that target sign where you have like a rounded focus of T2 signal and kind of a central dot of lower signal. So that's that target sign that you see with a neurofibroma. So we can see those areas. We've got, this one's pretty extensive. We've got intraorbital involvement, postseptal involvement along the lateral orbit on the left, kind of periorbital preseptal region. And then again, in that temporalis muscle, suprazygomatic masticator space. Inferiorly, this one was very extensive. It goes down into the left premaxillary region. And you can see these can be very contoured, deforming and disfiguring. You can imagine what this child's face looks like with this degree of plexiform on the left face. And you can see it go back into the buccal space here, in the parapharyngeal space, carotid space, parotid space. They can be quite transspatial. So, when you see these big transspatial T2 hyperintense lesions, in the setting of NF1, it's going to be a plexiform neurofibroma. But when we're encountering a patient that maybe doesn't have a history of NF1, the other differential that you'd want to consider with these transspatial T2 hyperintense lesions would be a venous malformation or a venolymphatic malformation. So those would be in your differential diagnosis. But in the setting of NF1, these are going to be plexiform neurofibromas. Another case here of a child with NF1 that had an associated moya-moya vasculopathy. So patients with NF1 are also at risk for moya-moya. So we can see, you know, if we go down to the bottom right image, this is the 3D MIP reconstruction of the MRA. And we can see that there's this progressive tapering of the supraclinoid ICA on the right. We don't see a well-defined M1 segment of the right middle cerebral artery. And we see all these prominent collaterals around the expected region, the M1. On the axial source images, again, we see that there's asymmetric flow-related signal in the supraclinoid ICA. We do not see the M1 segment in that top left image. Top right image, we see increased flow-related signal in the lateral lenticular striate vessels, and then kind of wrapping back even towards the ambient cisterns. We see all that collateralization from a moya-moya vasculopathy. All right, more plexiform neurofibromas in the spine. So they can be quite extensive as well. So image on the left here, we've got, again, kind of those target type lesions of the rounded foci of T2 signal in the right paraspinal region associated with these exiting nerve roots, and then in the right iliacus muscle. Another patient on the right image, bilateral involvement along the lumbosacral plexus. So very extensive. I will say, so for your NF1 patients in the spine, adding a coronal stir can be very helpful, particularly when there's these plexiform neurofibromas, just to get a nice evaluation of the extent of these. Because if you just have your axial and sagittal images, it can be hard to get the full extent because they can be very, very large. Other features in the spine that we can see with NF1 would be like a dural ectasia, where we see that kind of enlargement of the thecal sac and scalloping of those dorsal vertebral bodies. So we can see that with NF1 in the spine as well. Okay, so lots of imaging findings that we can see with neurofibromatosis type 1. So let's move on to our next phacomatous, tuberous sclerosis.
So this is also autosomal dominant, but even has a higher risk for just a spontaneous mutation. So majority of the time there is not a family history for this. And so what I'm thinking about, the main thing for me when kids are young coming in and it's raising my suspicion is actually these hypomelanotic macules. And what that means is they come in and they have these very light to white macules. Remember, just macules are flat, and so they have these flat white spots on their skin. And so when I'm seeing those in a young child, that's raising my suspicion. Facial angiofibromas, which is what this picture is, where you have these kind of lumps, bumps like around the cheeks and around that perialar, which is around that nose area. Those show up later. And so by that time, we hope most children would have already had a diagnosis of this, because those come up a little bit later in childhood. And then you can also see cafe au lait macules. Remember those brown macules that we were talking about with neurofibromatosis? You can see with this as well. As far as eyes, they can have retinal hamartomas, retinal astrocytoma, and then neurologically, seizures, nodules, cortical tubers, intracranial calcification. You're going to see all this imaging in these next slides. I'm sure Drew will show you. And then they also can have skeletal issues. They can get these dental pits, pulmonary issues. So we refer these children. They need a lot of specialty care. And so dermatology follows them, but lots of other specialties do as well.
Okay, so let's look at some imaging examples of TS. So top left image, we've got a coronal flare sequence, and this nicely depicts our T2 flare hyperintense lesions in the subcortical white matter, kind of blur that gray-white interface. So we see in the right parietal lobe, left parietal lobe. These are the areas that we see the cortical and subcortical tubers. On the left parietal region, we see that there's this linear band of T2 flare signal that's radiating towards the marginal lateral ventricle, and then we call those the radioglial bands. But basically, these are nice examples of the tubers that we see. You know, histopathologically, these are just areas of focal cortical dysplasia. So these are just TS, and that's why these patients have so many seizures. They just have widespread areas of cortical dysplasia. Top right image is an axial flare sequence, again, showing these areas of ill-defined T2 flare hyperintensity in the subcortical white matter, kind of right frontal, left parietal, left posterior frontal, again, blurring that neurointer interface, and you may or may not see the associated radioglial bands. On the axial T1 weighted sequence in the bottom left, nicely depicts the subependymal nodules that we see with tuberous sclerosis, often going to be T1 bright because of calcification. But you see these little bumps along the ependymal surface of the lateral ventricles that can even protrude into the ventricle, as we see here. These we don't really worry about too much. They usually don't change in size very much. But the ones that we worry about are the ones located down in the foramen Monroe for developing subependymal giant cell astrocytoma. So bottom right is just a susceptibility weight sequence, just showing the susceptibility associated with those subependymal nodules from the calcification. So here's an example, another patient. Again, we see the T2 flare lesion in the subcortical white matter with that radioglial band. But in this case, we have this rounded T2 hyperintense lesion centered at the left foramen row. And once they get large, greater than a centimeter and start enlarging, this is when we worry about the development of the subependymal giant cell astrocytoma. A low-grade tumor, but location can be bad, and we worry about developing obstructive hydrocephalus. So that's the issue with these. They do show enhancement, so we see very avid enhancement associated with that lesion. So you'll see those certainly on your rotation with us as well. Tuberous sclerosis, so nice example of those features. Okay, so next we're going to jump into the broad category of vascular anomalies. And the first condition we're going to discuss is impetimangioma. Before we even jump in, I just want to remind everyone, when we talk about vascular anomalies, two big categories. We have vascular tumors, vascular malformations. So vascular tumor, that's going to be one of the most common thing we're going to see in that category would be the infantile hemangioma. So I'll let Jenna go ahead and talk about some of the clinical features of an infantile hemangioma.
So this is my favorite part of the talk. I love vascular anomalies and find them really interesting. And I think this is great for you guys, as much as our radiology team can speak kind of the same language as we do, the most we get a lot more from when we're ordering imaging. So infantile hemangiomas, again, as Drew is pointing out, are in the vascular tumor category. They're benign tumors, but they're in that tumor category. We see these in about 4 to 5% of kids, and they follow a very predictable pattern where most of the time parents don't see much at birth. They may see a little bit of a bruising or a little redness. And then between 5 and 8 weeks of life, they really grow. This is the time where parents are really starting to be like, wow, something's happening here. And this is what usually brings them into their pediatrician and refers to us. So between 5 and 8 weeks, they go through this exponential growth, and then they continue to grow between 2 months and 6 months. They have this plateau phase between 6 months to 12 months where they're there, but they don't really change size. And then they start going away around 12 months, but it is slow. So we don't tell families that gone at 12 months because this is very, very slow involution, where about 90% of them are improved by the time kids are heading into kindergarten, so 4 or 5 years of age. They don't completely go away. They tend to leave behind some color change or some fibrofatty change, depending on the size of them. And we are in a brand new area kind of since 2014. We've had an FDA-approved treatment for hemangiomas with oral propranolol, which has changed drastically change the outcome of these. But most hemangiomas actually don't need treated, just time, and especially when they're in locations that aren't worrisome. We also have a topical medication we use for these. And then again, I mentioned that oral propranolol. And this is a good example of a superficial infantile hemangioma on the cheek of this baby. This cherry red look is very common. And so hemangiomas can have different appearances, and I think that this is really good for you guys to see. So superficial hemangiomas, that's that cherry red look. They just sit right on top of the skin. Deep hemangiomas, though, are the ones that a lot of times imaging gets ordered. So, you know, a provider may not really see or be aware of this, like those red kind of what we call telangiectasias over the top, but you can just see this deep blue hue. And so these, I think, sometimes get sent first for imaging and then come to us once the imaging is showing a hemangioma. These often, you know, families are concerned about a mass or some other entity going on here, and they have this deep blue hue. And then we see these mixed hemangiomas where they have this superficial component plus this deep component that's kind of raising up from the skin.
Okay, so let's look at a couple of imaging examples of this. And before I even talk about that, I just do want to reiterate, like what Jenna was saying, like it's really important for us to use the correct terminology in these cases when we're thinking about vascular anomalies, because especially in the kids, these patients, a lot, you know, if there's anything somewhat complex, they're going to go to the vascular anomalies clinic, which is a multidisciplinary clinic with dermatology and IR and neurology and ENT, plastic surgery, you know, all kinds of the specialties that can help care for these patients that have complex lesions or difficult to manage. So you really want to try to get these right and use the same language, and it's really helpful for them as well. So just want to encourage everybody to kind of commit to that. And, you know, there's the ISFA classification. You can always look that up online of the broad categories of how we do these. A little bit beyond our scope today, but just want to encourage you to look at that. Okay, so with infantile hemangiomas, very characteristic look on imaging. So the left image is our axial T2 weighted sequence, fat suppressed. So we really have nice lesional conspicuity of this lobulated T2 hyperintense lesion in the left inferior frontal scalp, kind of superomedial periorbital region. You can see internally there's some small foci of low signal that are indicative of flow voids. These are very, very vascular, so we can see some flow voids in them often. And then they enhance very, very avidly. So lobulated T2 hyperintense lesion with avid enhancement in the child of the correct age, infantile hemangioma. You know, when we think about a vascular lesion, a differential from an imaging standpoint, we want to think about like a venous malformation. Usually not as much of a dilemma for the clinician, like Jenna's saying, like they usually have a pretty good sense of what's going on. But for us, like we're like, okay, there's this enhancing lesion and I think it's vascular. What do I think it is? Venous malformations usually are going to be, they can be more lobulated, they're less defined, more likely to be transspatial. The enhancement isn't as avid. It kind of has more of the puddled pattern of enhancement. And you can actually do like a dynamic post-contrast sequence with venous malformations to help increase your confidence as well. And you'll see progressive enhancement over time. So I know we've done that on the adult side in the head and neck group. We've started doing some dynamic post-contrast images for the venous malformations. It can be very nice. So that's a thing to consider protocol-wise if you have a lesion that you aren't sure about to help kind of further characterize that and increase your confidence. But back to infantile hemangiomas. Another example here, left periorbital preseptal region, again, lobulated T2 hyperintense lesion with some internal low T2 foci that look like flow voids, very avid enhancement on the post-contrast sequence here. So no post-septal extension. So from our report, you know, we can be pretty confident that that's what this is. Other pertinence, we really wanted to say where this thing's going because that can impact management. So if it's going back into the orbit, we really want to discuss all that, what it's doing to the globe. Is there mass effect, proptosis? Is there compression of the optic nerve, et cetera?
Yeah, and I think that's a good point. So I don't frequently need to order imaging for infantile hemangiomas. You know, as a pediatric dermatologist, I can see these clinically. I make that diagnosis. But the times I'm ordering imaging is because it's not behaving as I'd expect. So it's either not responding to propranolol or it's growing more quickly than I would expect it to be. And then I'm trying to consider whether I'm missing something else. And then the other times is definitely with the globe. So in working with ophthalmology, sometimes we're concerned about how deep it's going. And so that can be beneficial.
Okay, so as we're continuing our discussion on infantile hemangiomas, let's talk about a specific category of infantile hemangiomas that raises concern for a syndrome called face syndrome.
And this is something we've really stressed a lot in our dermatology clinics and when we're talking with pediatric providers. I think it's good for everyone to be aware, you know, there is something called a segmental infantile hemangioma. And then there's capillary malformations or port wine stains. And again, that's that category we're talking about, tumors in the vascular tumor category versus the vascular malformation category. They're both red, but they're not the same. And so an infantile hemangioma, again, I talked about they're usually absent at birth. There may be something subtle red there, but then they kind of grow over time and proliferate. And when they're covering a segment of the body, either the face or arm or different areas, we think about those being segmental infantile hemangiomas. And those can be associated with a syndrome called face syndrome and a syndrome called lumbar syndrome. And we're going to talk about those. That is different from a capillary malformation, where this picture is showing this red hue that you have on the cheek of this child. Those are usually evident at birth. Babies are born with these. They grow with the children, but they don't thicken up and change appearance over time besides kind of proportionally growing. Capillary malformations, or what we used to call port wine stains, or another term, port wine birthmarks, those are what we worry about with Sturge-Weber. So when we're talking about hemangiomas, we're not worried about Sturge-Weber syndrome, but we're imaging and concerns about face syndrome. And that's what I really want to emphasize. So face syndrome, there are these segments that we talk about. You can see this picture on the right. There's a 4 different segments of the face. This is different than what we think about or used to talk about with like V1, V2, V3 that you may have learned in medical school when people used to be talking about Sturge-Weber syndrome. So segments are these embryologic formations that happen when babies are born and are associated with the risk for face syndrome. So what face syndrome is the P stands for posterior fossa anomalies, H is that hemangioma, A is arterial lesions. So we're thinking about carotid, the blood vessels having changes that can raise the concerns. C is cardiac abnormalities or coarctation of the aorta. And E is eye anomalies. So the highest risk for face syndrome is when you have a really large segmental infantile hemangioma, over 25 square centimeters, or when you have 3 segments involved. I think about imaging though when something's about 3 to 4 centimeters. When I see a hemangioma that is in a segmental distribution, so not one of these focal hemangiomas I can draw like kind of a circle around, is how I teach our dermatology resident. When it's kind of taking up more of that area, that's when I'm concerned about face syndrome. And we immediately then go to ordering imaging to help us make that diagnosis because it's part of the criteria. And so the imaging workup for face syndrome, do you want to?
Yeah, so they have pretty set guidelines of what should be ordered to work up face syndrome, and that includes an MRI of the brain without and with IV contrast, an MRI of the neck without and with contrast, and an MRA of the head and neck, and we can usually do that without contrast, just our time of flight imaging. The MRI soft tissue neck without and with contrast is in their guidelines. I don't really understand why, personally. These are segmental distribution on the face, so it's not like we're worried about deep extension typically to involve airway and things of that sort, but I guess that's probably why it's in. So maybe if it was going back into the orbit or something, that maybe you'd have better imaging of that region rather than just seeing that on brain imaging. But I haven't really understood why a neck is included in these. You can have airway hemangiomas and things of that sort that a neck MRI is certainly warranted and helpful to have, but those usually aren't the patients that we're working up for face syndrome. So that's a bit of an asterisk and a question mark for me personally, but it is in the guidelines, so you will see that ordered.
And just to emphasize, so a segmental hemangioma kind of in what we call like in the mandibular region, those have a higher risk for, so we're talking about segment 3. So if you have a segmental hemangioma in segment 3, that is a high risk for airway hemangiomas. And so when you see that, that's the ones that we need to see for airway involvement, but it's not necessarily to help us with the face diagnosis, but those are ones that we do think about airway involvement.
Well, there you go. I just learned something too, guys. So that's great. Thank you, Jenna. So the beard-like distribution, F3 segment, increased risk of airway hemangioma. So that would explain the neck. So
yes,
thank you.
But it is an asterisk because it's not like it's not something it has to be every single time, but for the face syndrome, the big publication on the criteria, it lists always ordering that. So that's why you'll see us as pediatric dermatologists ordering it.
Great. Okay. So let's jump into some imaging examples of face syndrome. So left image, axial T2-weighted sequence, probably the most common posterior fossa anomaly you're going to see with patients that have face syndrome is going to just be cerebellar hypoplasia. So we can see that the right cerebellar hemisphere is small in size. We have that asymmetric prominence of the subarachnoid space overlying the cerebellar hemisphere. So right cerebellar hypoplasia here. Middle image is a post-contrast T1, and we can see that there's this subtle enhancing lesion in the right internal auditory canal. So that's a little hemangioma that's in the iAOC. So we can see that from time to time. And then we have an MRA, the 3D MIP, kind of coronally oriented here. And we look at there's asymmetry of the internal carotid arteries. So we see that the right one is small in size relative to the left. There's tortuosity of the vessel as well. So that would be a feature of one of the arterial anomalies that we can see with face syndrome. So you can have tortuosity, you can have hypoplasia, you can have complete aplasia, and it's going to be usually of those major cervical or intracranial arteries. So you can see all kinds of really interesting anatomy in these patients, but this would be an example of some of the features we see with face syndrome. Another patient here, another one from Riley, we can see that there's right cerebellar hypoplasia, again, with prominence of that extraaxial space. This one, you really almost wonder, is this a big arachnoid cyst, just given that, this vessel is kind of hugging the cerebellar hemisphere. Other features that we can see on this T2-weighted sequence are there's enlargement of Meckel's cave on the right. So that's a feature that you can see with face syndrome is asymmetric enlargement of Meckel's cave. And that usually occurs on the side. If the segmental hemangioma is on one side of the face, it often occurs on that side. I think the thought is that there was an infantile hemangioma there previously that's maybe even involuted, but you can see that from time to time. We can see these very tortuous flow voids of the right cavernous ICA here. So we've got some of the arterial features as well. And then we have kind of posterolateral elongation in the right globe. So there's a staphyloma. So we've got an eye anomaly here as well. So lots of features on just this one slice that we can appreciate. Here's the T1 post-contrast sequence in that child, and they also had an enhancing lesion in the right IC. So another hemangioma in that region. And then again, you can see that really marked enlargement of Meckel's cave kind of shows that nicely on the post-contrast sequence. Another image here, so we can see that there's some abnormalities here in regards to cardiac anomalies. We can see that there's enlargement and tortuosity of the right ICA on the CTA sequence, and tortuosity of and enlargement of the right cavernous and kind of supraclavicular ICA, enlargement of Meckel's cave here as well. Here's an example of Dandy Walker malformation, which would be another posterior fossa anomaly that you can see in these children. We've got upturned and rotated cerebellar vermis with inferior vermic hypoplasia, this cystic enlargement of the fourth ventricle, which widely communicates with the posterior fossa cyst. There is some mild cerebellar hypoplasia. We've got torcular lambdoid inversion, so features of Dandy Walker, which would be another posterior fossa anomaly that you can see with one of the conditions of face syndrome. So there's some major and minor diagnostic criteria, and that's all published online. It's kind of beyond the scope, but it's not a bad idea to take a look at that. When you're reading one of these cases, I encourage you to just Google the face syndrome diagnostic criteria, and it gives you an idea of what the clinician is looking for to determine can I give them the diagnosis of face syndrome. So that can be very helpful just to know what you should be reporting on. So I think that's something I would encourage you to look at.
And just to emphasize that, I didn't really talk too much at Go In because it can be a lecture unto itself, but why do we care if they have face syndrome? So face syndrome can be associated with some like developmental delay. They can have increased risk for headaches depending on their cerebrovascular. They can have cardiac anomalies. And so it really is important for us to know we actually have to be really careful with propranolol. They have a lot of vessel changes. Then we need to be careful about the doses of propranolol, because it can increase risk for stroke. And so it's important for sometimes we don't start the treatment until we have this imaging to know that everything is looking okay. And it can help us kind of manage who needs referral to neurology. And so lumbar syndrome, we think about being kind of the sister disease of kind of the same thing happening over the lumbosacral spine. We do not have genetic. So this is another thing that comes up sometimes is like people refer to genetics for these. We actually don't know. There's lots of studies going into like what is causing these. They are likely some type of somatic mutation that's happening, but we haven't found a gene or association for these in comparison to like Sturge-Weber or our port wine stains, which we now have genetic mutations for. So lumbar syndrome is another acronym. So L stands for a lower body or lumbosacral hemangioma. They can also have lipomas or other cutaneous abnormalities, those skin tags. And so remember back into one of those earlier slides when we were talking about spinal dysraphism, and I was talking about the criteria for who to image. And I talked about those hemangiomas, that the larger hemangiomas raise my suspicion. And that's where this is coming from too, because these more segmental, you can kind of see this is distributed. We talk about a butterfly look to this over the lower spine, buttocks area. These can have a high risk association for this lumbar syndrome. They can have associated urogenital abnormalities, and they have a lot of ulcerations. So ulcerations where there's a lot of wounds, a lot of oozing. This is something I'm managing, really seeing these kids back frequently. It can cause a lot of pain. And then myelopathy, so the spinal dysraphism, bony deformities. They can have anorectal and arterial anomalies, and then renal anomalies.
All right, so this kind of has a nice overlap with our spinal dysraphism section earlier, because that's what we're going to see with lumbar syndrome. So this was an example, a patient that had one of those lumbosacral segmental hemangiomas, which I will say a lot of times, you know, if these are like kind of more flat or plaque-like, you don't really appreciate them that well on imaging, and that's not the purpose of doing the exam. So it's not something you need to like fret about. We're looking for the associated anomalies, particularly dysraphism. So I just want to point that out. So here, sagittal T1 weighted sequence, we can see that there is a dorsal dysraphism. We have a low-lying cord. It's kind of hard to appreciate given the this one sequence, but it is coming down low, and we have an interface with intraspinal fat here. So this was a lipomyelocele that was associated with that impetimangioma over line. So this was a patient that had lumbar syndrome, had many of the other features that Jenna just described. Okay, so let's go to our vascular malformation category now within vascular anomalies, and specifically talk about capillary malformations or port wine stains.
And so not everything red is a hemangioma. I stress that a lot. So this is a really common issue that kind of comes up. But remember, we talked about that difference between hemangioma and capillary malformation. So this picture on the left is actually an early hemangioma. See how it's not kind of this diffuse or homogeneous pigmentation. You can see some darker thickening. They can have a similar distribution, but they are very, very different. So on the left, I would be thinking about face syndrome, and I would be ordering imaging to kind of think about that. On the right, this is a port wine stain, capillary malformation, port wine birthmark, and that I am concerned about risk for Sturge-Weber syndrome, and so different things to be concerned about. So capillary malformations have lots of terms. I think that that's a problem over time. You know, because of that, it can be confusing. So capillary malformation is the same as a port wine stain, which is the same as an old term I don't use anymore, but a nevus flameus. And actually, there's a big push to kind of, again, as time goes through, to get rid of the term as stain. So you'll see in a lot of new publications, people use the term port wine birthmark rather than port wine stain. These are present at birth. They're flat, they're a little purple. Babies come out all ruddy, so they tend to have a lot of redness everywhere, but these tend to be a lot darker. And then they don't change. Besides, they can fluctuate if kids are like crying and really upset or hot, they have fevers. Temperature changes can cause more of that dilation of those blood vessels and cause them to be a lot redder at times. But overall, they stay the same look. And so there is a big change that's happened over time. So this is a publication from one of our journals in 2021 talking about the risk for Sturge-Weber. And so you may have learned in medical school the V1, V2, V3. We don't actually use those terms or try to get away from using those terms anymore and think about what location. And so we talk about, this is that PWBs, that what I was emphasizing, that people talk about port wine birthmarks. So port wine birthmarks involving the forehead, the upper eyelids, and that midline frontonasal prominence. Those are the ones that have a much higher risk for Sturge-Weber. So when I see a capillary malformation in this location, I'm ordering imaging. Or if they're hemifacial, so they take up multiple of those segments, not just the forehead region, but also kind of coming down into that cheek and lower eyelid. And then the other concern are the median ones. So they're just kind of down the center of the face. Now, there's a little caveat to that. A lot of babies are born with stork bites. Stork bites can look like a capillary malformation and be located in that glabella midline forehead. Those are a little different. They fade over time. They're not this confluent pigmentation, and so we don't worry about those with Sturge-Weber. So screening for Sturge-Weber is still a little controversial. If you can survey lots of different pediatric dermatologists across the internationally, and everyone does these a little bit differently. We're trying to come up with guidelines. But an MRI does have pretty high specificity and a positive predictive value. If an MRI screening is negative, though, it doesn't completely exclude Sturge-Weber, and we still have to follow them over time, especially with those that are a little bit higher risk location. Infants with a high risk port wine stain always require close neurodevelopmental assessments. So I'm always talking with them about development. And when they're in these high risk locations, I'm referring to neurology to give just seizure education and monitoring. And so if a port wine involves any part of the forehead, you're getting an MRI. We like to do these early. I also send to ophthalmology because there's a risk for glaucoma. And sometimes there is a risk for congenital glaucoma in some children. And so we're getting them in. If the MRI is normal, I just refer to neurology just to have them have good seizure education in case something would develop. But if it's abnormal, then we're getting them urgently into neurology, repeating MRIs. Sometimes they are getting put on prophylactic aspirin and having close assessments, and then they see ophthalmology at least every year.
Okay, so imaging wise, kind of characteristic looks here for Sturge-Weber. So on the left image, we've got an axial 2-2 weighted sequence. We can see that there's kind of asymmetric prominence of the left parieto-temporal or parieto-temporal occipital sulci, suggesting some volume loss. You can see there's a little bit of prominence of the atrium of an occipital horn of the left lateral ventricle. On the post-contrast image in the middle, we can see that there's enlargement of the glomus of the choroid plexus in that atrium of left lateral ventricle. So that's a feature that's well known with Sturge. And then we have kind of this diffuse leptomeningeal enhancement of the parieto-temporal and occipital region. The right image is a post-contrast flare, and this is a sequence I really would encourage everyone to add on to their protocol if the indication is to screen for Sturge-Weber. So post-contrast flare is your most sensitive sequence that we can run for leptomeningeal disease in general. So with Sturge, as we have the leptomeningeal enhancement from the Peel angiomatosis, you have very high sensitivity and really good contrast to detect this. So the post-contrast flare really is a nice sequence when you're looking for those really early subtle cases of Sturge-Weber that this may be the only sequence that you see an abnormality on. So very great sequence to add on for these cases to increase your sensitivity. Here's an example, much later stage. We can see from SAT-DX, middle image showing a post-contrast T1, showing that diffuse leptomeningeal enhancement from the Peel angioma, very marked right hemispheric volume loss with prominence of the sulci and subarachnoid spaces. And then a CT image showing that gyroform calcification as a result of probable chronic venous ischemia. Okay, so that was Sturge-Weber with our discussion of port wine stains. So our last topic is going to be connective tissue diseases, and we're just going to cover one connective tissue disorder today, and that's morphia.
Yeah, this is one of those that does require ordering imaging. So that's why we wanted to include it. And it's a little bit of one that maybe some people haven't heard of. And so morphia is a autoimmune disorder where you get these localized areas of sclerosis of the skin. And so what that means is that a child comes into me and they have this, sometimes it can be really, really subtle. Sometimes it can be really impressive if it's gone unnoted. But when you feel the skin, it's like bound down, it's thick. Sometimes it's hollowed out. And it can be accompanied by hair loss. They can have seizures, headaches, trigeminal neuralgia, issues with their eye muscles, and then intracerebral atrophy and white matter changes, which is why we tend to order imaging for these.
Okay, so the other disorder that we can see is called, you can call this localized scleroderma would be the other term for morphia that you may see in your requisitions. So from an imaging standpoint, we usually can see that atrophy of the fat and the scalp or face structures of the areas of involvement. So here on our axial T1 weighted sequence, we can see that there's focal thinning of the right frontal scalp and skin. The calvarium is going to be intact in most of these cases, and in this case it is. It's hard to tell this on the slice, but it is. And this is one of the features that we can see in intracranially with patients with localized scleroderma. These areas of kind of ill-defined flare hyperintensity. So we see this increased T2 flare signal in the right frontal subcortical and periventricular white matter. Really just kind of a non-specific gliosis is how we would read it. But, these patients, as Jenna said, can have seizures and things of that sort. This usually occurs ipsilateral to the side of the localized scleroderma. Here's another example. Again, subtle findings. This would be really hard for us to appreciate prospectively without the history. But there's very subtle asymmetry of the facial sub-Q fat. You can see that the left is a little bit decreased relative to the right as far as the bulk of that sub-Q fat. Also, you look at the left maxilla, this patient has a little bit of hypoplasia of that left maxilla, just a little bit smaller than the right. So it has another feature. There's some bony findings. And then on the T2 flare sequence, we've got a couple of dots of T2 flare hyperintensity signal on the subcortical white matter here, the left superior frontal gyrus, entirely nonspecific, right? We see these all the time. These could just be the nonspecific foci gliosis from prior ischemia, demyelination, infection, trauma, right? Whole laundry list of disorders. But in the setting of localized scleroderma, it's something we want to mention because that can be associated, related to that entity. When we see this, you want to also look for other features. So, sometimes we have cases of like hemifacial microsomia. So you want to look at the whole global picture, look at the muscles of mastication, look at the mandible, the maxilla, the parotid, look for EAC atresia, all of those features. So, but in these cases of just localized scleroderma, it's usually going to be cutaneous only. That would be the only finding. So, sorry if you hear my daughter coming down. They've been very good. They're upstairs and they're behaving. So, so I think that wraps up the topics we wanted to cover today. So in summary, we reviewed lots of cutaneous conditions that Jenna and pediatric dermatologists encounter in their clinics, and talked about, how they approach those patients and why and what they need from an imaging perspective. And that helps us report better and be more relevant. We discussed, what patients need to be imaged and how we can optimize our protocols to best answer the question. And then we reviewed lots of illustrated examples of those imaging findings. So that's all we had for you today. More than happy to answer some questions if anybody has any. Hopefully it was helpful. And when I was deciding a subspecialty, Jenna was already gung-ho about peds derm, and we had even talked about, like, if I do peds neuroradiology, we'll be able to collaborate. So this was fun that Tanya had the idea that we were actually able to do this. So we enjoyed putting it together. So
yes, thank you.
Thank you so much. This is amazing. I love this lecture. Yeah, I think I have learned a lot. So you can see my note. I have like 3 pages. I learned a lot of new things. Yeah. So thank you so much, Jenna, for giving us a lecture, and for Drew to collaborate these things, put things together. Any questions from our trainee people here? Fantastic. Yeah, Dr. Moshe, fantastic lectures.
Thank you.
Yes. I have a questions about the protocol on the what is it like the neurocutaneous melanosis.
Yes.
Yeah, because like we normally don't give contrast, but according to one paper that Jenna showed here, that they do like the contrast for the whole CNS.
Yeah. So it's great you asked that, Tanya, because Jenna and I have talked about this numerous times. There's not clear-cut guidelines in the literature of whether or not to give contrast. You'll see sometimes they'll say to give it, but I think the most recent paper that we had found that we thought was well done said without contrast.
Yes.
And I think that it's very reasonable to not give contrast in these, given that the bulk of the findings are parenchymal melanosis. You're gonna, if it's early, right, you're gonna have the T1 hyperintensity on that unmyelinated brain. In regards to leptomeningeal disease, you know, if it's T1 bright, you're gonna see it without contrast. Even in our flare images, you know, even if it wasn't that T1 bright, you should have some indication that there's abnormality on the flare sequence. So I think that protocol-wise, it's completely reasonable to do without contrast, in my opinion. If you see leptomeningeal disease, I think at that point, you're probably going to want to start following them with contrast. The question is if you're looking at something intrinsically T1 bright, how are you appreciating enhancement, right? So that's what's a little bit confusing, right? And that's with melanoma, you know, sometimes it's not. If you think about our melanoma metastases that we see in adults, right? They aren't always intrinsically T1 bright, right?
True.
So I think that there is a role to give contrast once you have leptomeningeal disease for that reason. But just from a screening perspective, I agree. I think without contrast is sufficient.
I do agree. Yeah, because sometimes I was debating like should I give contrast or not,
Right.
and since sometimes patients are under GA or sedation, so that's why like, okay, go ahead and give contrast if it's like
right,
after.
because you want to err on the side of caution. Exactly. Done the exact same thing. So, but yes, I agree. I think without contrast is reasonable.
Yes. And I think like one thing that Jenna explained about the new classification for the pod-wise strain, that makes sense because in the past when we're talking about the pod-wise strain, it's just like the brain finding usually on the same side.
Yeah.
Right, but right now if like it's forehead.
Yes.
So it can be like any side.
Yes, exactly. Yep. And sometimes they really just can involve the upper eyelid. And you know, those are high risk as well.
Yeah, that makes sense. Yeah. Any questions from our people here? Yes. So I posed one questions on the Facebook that what are dermatologists looking for in the setting of the patient with birthmark?
With a birthmark, is that what you said?
Yes.
Yeah, so it kind of depends on what the birthmark is. So kind of going back, you know, if you consider aplasia cutis a birthmark, right, we're looking for intracranial extension. So that's why I would order imaging for that type of birthmark. If it's a birthmark on the face and it's a capillary malformation, that port wine stain birthmark, I'm looking for Sturge-Weber risks. If it's a birthmark, so to speak, of an infantile hemangioma that's in a segment, I'm doing imaging to look for that face syndrome. If it's just a plain hemangioma, not segmentally distributed, I may be ordering imaging just to make sure that it's consistent with a hemangioma. If it's not behaving well, growing really quickly, or not responding to treatment, my reason would be for you guys to help me say, oh, this looks definitely like a hemangioma, or is this a nasal glioma, which is one of those things that sometimes comes up for us, like if it's really expanding, or a venous malformation, which you guys can help us kind of differentiate between those.
And in the spine, thinking about dysraphism, an underlying dysraphism, right?
Yeah. Yes, that makes sense. Yeah. Let's see.
It takes a good impression though, right? For you guys, I think, you know, you need the clinician to help provide you with what we're looking for. And so that's my goal when I'm, you know, doing teaching with our dermatology residents and our fellows is to help you guys by giving you guys a good clinical, I wouldn't want someone just to write like imaging hemangioma, right? That's not helpful for you. It's helpful to know that this is imaging because we're worried about face syndrome. And so the more we can provide you, the better.
We can give a much better tailored report and really provide useful, actionable information. So yeah.
True. I love it. Yeah. So if you don't have any questions from here, my last questions for you. So it's like we're talking about the dermoid, like a dermoid cyst that you can see like on the nasal or maybe like a lateral orbital rims. Is it are you able to differentiate between like a dermoid and epidermoid on the clinical, on the physical examination? And also, is it important that you need to know exactly if this is a dermoid or epidermoid in terms of the clinical and treatment?
Yeah, so a little bit in my life, so I do almost all pediatrics. And so a true epidermal inclusion cyst is very, very rare. And so in children, more times I'm looking for a to see if it's a dermoid, because I don't really think about epidermal inclusion cysts happening as much as my infants. Management, if it would be an epidermal inclusion, so let's say we're talking about more like an adolescent, which would be a little bit more likely to be seen. It does change the management a little bit, but if it's recurring and filling up, we do tend to excise those, and so they all kind of go to surgery at that point. And so more the pathologist can help us then differentiate between those.
Yeah, so I think that those are the ones that we see, Tanya, are all these younger infants and much younger patients, whether it be incidental or not. And I think that those probably are more likely to be dermoids.
Yes. But sometimes it's quite difficult to differentiate on the imaging characteristic, right?
Oh, for sure.
Yeah.
Yes. And for us clinically too, and again, if I'm like seeing a young kid, it's just because based off of age alone that I'm almost always thinking dermoid. Exactly. In an adolescent or older child that I can see more likely to see epidermal inclusion cysts, they sometimes have a little punctum on the top. And so clinically that can help me differentiate them, but it wouldn't be something I'd expect you guys to by imaging.
Okay, sounds good. Thank you so much for joining us today. So for the people at IU, please complete the evaluation form for me, so I can know that which one is better or how can we improve this lecture series. And for the people from Thailand, so we're gonna send you out evaluation form link. Please complete those things by Friday, and you will get a CME credit from like a Thai CME credit. And please feel free to share these lectures, YouTube, Facebook, to your friends. So I think this is one of the good lectures that we have that have like the collaboration between like two subspecialty. This is a great idea. And thank you so much, Drew and Jenna Streicher, for lectures, for giving us this thing. And I have learned a lot. Thank you so much.
Thank you for having us.
Thank you. Bye-bye.
Bye.